right, good afternoon, everyone. Thanks for attending this later afternoon session. My co-moderator will be here in a moment, Dr. David Rothstein, and I'm Bethany Slater from the University of Chicago. We are excited for this Quick Shot 3 fetal cancer and colorectal session. Our first presenter today will be the presentation entitled Pediatric, Adolescent, and Young Adult AYA Peritoneal and Pleural Mesothelioma, a National Cancer Database Review, presented by Dr. Colleen Nofi.
Good afternoon. My name is Colleen Nofi, and I'm a general surgery resident at Northwell Health, and I'm very excited to present our work today on mesothelioma. Mesothelioma is a rare malignancy in children, adolescents, and young adults, affecting less than 0.1 per 100,000 patients annually in the U.S. Previous literature is largely limited to case reports, case series, and small retrospective reviews. In this study, we aim to improve our understanding of the disease characteristics and treatments utilized for mesothelioma. To do so, we utilized the National Cancer Database from 2004 to 2019 to look at peritoneal and pleural mesothelioma in pediatric, adolescent, and young adult patients. Our study included 570 cases, 363 of which were peritoneal mesothelioma, and 207 of which were pleural mesothelioma. We found that patients with peritoneal mesothelioma were more likely to be female, whereas patients with pleural mesothelioma were more likely male. Patients treated for peritoneal mesothelioma were more likely to have radical surgery, and patients with peritoneal and patients with pleural mesothelioma had a similar receipt of chemotherapy. In regard to outcomes, we performed multivariable modeling to determine predictors of overall survival. In our peritoneal mesothelioma model, we found that surgical resection was associated with improved overall survival, whereas male sex and radiation were associated with worse overall survival. In our pleural mesothelioma model, we found that intraoperative chemotherapy was associated with improved overall survival, whereas black race was associated with worse overall survival. We performed Kaplan-Meier analyses to look at overall survival. In this figure, you can see that patients with peritoneal mesothelioma had a much better survival curve than patients with pleural mesothelioma. The mean overall survival for peritoneal mesothelioma was 125 months, and for pleural mesothelioma was only 69 months. When we performed a sub-analysis looking at pediatric and young adult patients separately, we first found that pediatric patients had overall better outcomes. We also corroborated better survival outcomes for peritoneal disease versus pleural disease in these subgroups. In conclusion, the study was the largest cohort of pediatric and AYA patients describing peritoneal and pleural mesothelioma. We revealed that sex, race, and treatment modality significantly influenced overall survival. And finally, that younger patients and patients with peritoneal disease exhibited better outcomes. Thank you, and I'm happy to take any questions.
We'll have time for just one quick question if someone wants to come to the mic.
So my question is this a disease-specific outcome database?
It's an excellent question. It's a limitation of the NCDB. One of the only long-term outcomes we have is overall survival. So it would be a limitation of the database, and we need further data to actually look at disease-specific outcomes like event-free survival and disease-free survival.
Thank you very much.
Thank you.
Our next talk is entitled Early Experience in Developing 3D Printing-Based Thoracoscopic Surgery Simulator for Esophageal Atresia, presented by Dr. Jung-Ki Young.
Thank you for your kind introduction. So it's always been very difficult for us to teach surgery for our residents and fellows due to various reasons. And this beautiful 3D printing hybrid model combined with animal bowels have been used for teaching surgery of esophageal atresia. So our purpose is to develop and check its effectiveness in the education of pediatric surgeons of 3D-printed thoracoscopic surgery simulator of esophageal atresia. And we selected a patient who had a CT scan before esophageal atresia operation, and then built a 3D simulate 3D model with from this CT scan, and built this 3D printing based simulator with thoracic cavity, replaceable skin, and also replaceable esophagus and adjacent organs. So we applied this for 14 pediatric surgeons with relatively small experience with esophageal atresia. And we evaluated this simulator with 5 domains, and all of them had average of more than 4 out of 5 points. And all the participants said that this simulator can be considered for esophageal atresia as repair training, mostly with slight improvement. So using 3D printing, we developed an initial version of the thoracoscopic surgery simulator, and this current version could be used as training tool for pediatric surgeons, and we'll continue to develop various 3D printing simulators, which is the final goal of this project. Thank you.
This is open for one question.
Thank you for the presentation. How do you think about this model in the evolving world of AR and VR? And what role do you think 3D printed models will have as we consider those modalities in future training?
Thank you for your great question. Actually, AR and VR is one of the fields that we are applying for the developing surgery simulator. We have some issues in 3D printing because we can use this just for once, and it should be discarded after the use. So we are developing some simulators applying VR and AR, but the obstacle is the devices are not perfect for education currently, but it'll be better after the improvement of the devices. Thank you.
Thank you very much. Our next talk is entitled Neurodivergent Patients Who Undergone Malone Appendicostomy Achieve Fecal Social Continence in the Same Amount of Time as Neurotypical Patients. This will be presented by Dr. Shimon Jacobs.
Thank you. Neurodivergent patients with soiling due to functional constipation may have difficulty tolerating laxatives, suppositories, or rectal enemas on a daily basis. Antegrade continence enemas may be an effective management tool to overcome these challenges in these patients. Our aim is to determine whether there is a difference in the rate of resolution and the time required to achieve resolution of soiling between neurodivergent and neurotypical patients after an ACE procedure. We performed a single institution retrospective review of pediatric patients referred for functional constipation who failed medical therapy and subsequently underwent an ACE procedure within a 2.5-year period. We looked at various presence of neurodivergent diagnoses, and our primary outcome was resolution of soiling, we defined as less than or equal to 1 accident per week with no significant stool burden on X-ray. Patients with constipation only without soiling were excluded, and we performed log-rank testing and Kaplan-Meier survival analysis. 51 patients underwent an ACE for functional constipation. 61% of these patients had constipation and soiling. 3/4 of these patients were neurodivergent. The graph on the right represents the successful resolution of soiling over time in months, with the neurotypical patients represented in blue and neurodivergent patients represented in yellow. Successful resolution was maintained at 90% at a median 8.7 months follow-up in the neurodivergent group, and at a similar high rate for neurotypical patients. We detected no difference in median time to resolution of soiling, with half of neurotypical patients achieving success in 1.2 months and half of neurodivergent patients achieving success in 1.7 months. In conclusion, functional constipation in soiling patients had a high rate of neurodiversity. Soiling was resolved within 2 months after an ACE procedure for a majority of the patients, and ACE was equally effective in neurodiverse and neurotypical patients. Thank you.
Great presentation, and thanks. And I always struggle with what to do with these neurodivergent patients. But did you have any insight into what you did? Our group hesitates to put Malone's in these patients because just as those patients fear getting catheterized via the rectum, they fear being catheterized anywhere. So those patients, in my practice anyway, fear having a tube placed in their umbilicus just as much as they do in their rectum.
Right. I think our data shows that we have had significant success in the neurodivergent population at having them tolerate and also be successful at achieving both resolution of constipation and soiling. Sometimes with the particularly difficult patients, we can pre-train them a little bit to manage catheters by giving them the family catheters to teach the patient that this is what's going to happen. And we also involve autism behavior clinics and other providers who are involved in the patient's care in order to get success.
Just, can I ask a follow-up question?
Sure.
Quick, short. Did you typically, I know your program does bowel management via the rectum first and then does them alone. Did these patients undergo bowel management first or did they go straight to?
Most of these patients undergo straight to Malone. I think data from PCPLC and our protocol has also been that we don't require patients to undergo a rectal enema regimen before doing antegrade. And that has been successful.
Thank you very much.
Thank you.
Our next talk is entitled Factors Associated with Hospitalization Cost in the Initial Management of Esophageal Atresia, a National Cohort Study, presented by Dr. Annalise Pennikins.
Thank you for the opportunity to present our work in collaboration with Yale. Briefly, esophageal atresia is thought to have some of the highest costs associated with management of any pediatric surgical problems, though the exact cost burden is unknown. We sought to determine the costs associated with the initial management of EA and key mediators of that cost. We accomplished this by using the Pediatric Health Information Systems database, an administrative database of nearly 50 children's hospitals across the nation. We generated a cohort of esophageal atresia patients by pulling those with both a diagnosis code of EA or TEF, as well as a procedure code for repair. We excluded any patients who underwent cardiac surgery from the analysis, as this would confound cost figures, and patient information as well as adjusted cost figures were obtained. Our final cohort consisted of nearly 1,000 patients. Infants were repaired at a median age of day of life 2 and had a median length of stay of 34 days. However, length of stay was varied with an interquartile range from less than a month to over 2.5 months. Adjusted total cost varied widely, with a median value well over $500,000 and an IQR of $300,000 to over $1.1 million. When broken down by specific cost categories, which included clinical charges, imaging, laboratory, room and board, pharmacy, and supplies, the costs associated with room and board were not only the highest at nearly $400,000, but carried much of the variability, with the IQR ranging from $219,000 to $841,000. When looking at markers of disease severity, postoperative complications, and resource utilization, all were significant on univariate analyses. However, on multivariable logistic regression, the only significant factors were presence of a cardiac anomaly, which increases total cost by approximately $51,000, ventilator days, with each additional day increasing total cost by approximately $5,000, and finally, hospital length of stay, with each additional day in-house increasing total cost by nearly $13,000. Our data demonstrate that the total cost of the initial management of EA is over $500,000, and that difference in management are not driving that cost, but rather it's the extended lengths of stay. While it may seem obvious that more days in the hospital means higher cost, it's critical to look at and understand these data, both to confirm our assumption and to direct further research to help mitigate these costs. We believe that a multi-center studies with more granular clinical data will be beneficial to identify factors associated with increasing lengths of stay and any possible areas for improvement that could decrease hospital stays and defray costs. Thank you.
Dan Von Allman, Cincinnati. Hey, nice paper. Can you just clarify for me, when you say, is it costs or is it charges that you're reporting?
It's an adjusted cost figure. So the FIS database has charges, which is not adjusted for inflation or like yearly inflation or cost of living and such for the different areas. So this is the billing database has its own way of adjusting to kind of even out across institutions and across years that cost.
Right, because it's very difficult to get a handle on cost.
Yes, yeah.
And charges don't necessarily.
Yeah, so they do have charges as well, and we saw that those were kind of all over the board, and this was an adjusted cost figure.
Great, thank
Yep,
you.
yep.
Thank you very much.
Thank you.
Our next presentation is entitled Factors Associated with Non-Completion of a Pediatric Bariatric Surgery Program, presented by Dr. Hannah Phelps.
Thank you for the opportunity to share this work. I have nothing to disclose. This audience needs no introduction to the prevalence and severity of pediatric obesity. Due to excellent outcomes from bariatric surgery, the American Academy of Pediatrics has advocated its use in pediatric patients in multiple consensus statements. However, only a small proportion of U.S. pediatric patients successfully completes the procedure. Moreover, the process to become a candidate for bariatric surgery is rigorous with multiple steps and requirements. We therefore aimed to, first of all, quantify the proportion of patients that drop out of a bariatric surgery pathway and the point at which they do so, and second, to identify patient and environmental factors associated with non-completion of the program. To do this, we reviewed patients less than 18 years old referred to our center for comprehensive bariatric surgery evaluation between 2018 and 2022. Of 60 patients referred, 20 patients successfully completed the procedure, leaving 40 non-completers. Completion status was then correlated with demographics, medical and psychosocial history, environmental factors, and referral patterns. Within our cohort, male gender was more commonly associated with non-completion of the procedure. In addition, non-completers were more commonly living in lower income neighborhoods and endured significant environmental or family stressors. Importantly, there were no differences in medical comorbidities, psychosocial comorbidities, or referral patterns between the two groups. And interestingly, we found that completion of the polysomnography as part of the preoperative pathway significantly predicted ultimate completion of bariatric surgery. So in conclusion, non-completion of a pediatric bariatric surgery pathway was more prevalent among male patients from lower income neighborhoods with environmental stressors, indicating further disparity in the care of pediatric patients with obesity. These findings underscore the need for prospective investigation into barriers to pediatric bariatric surgery, particularly in the setting of environmental stressors and overall cost of the process. Thank you for your attention, and I welcome any questions.
While somebody else is coming up, thanks for that. It adds to some of the other data out there. Do you have a strict definition of stressors? And in asking that, did you risk kind of leading the witness, so to speak?
So thank you for that question. That's definitely a limitation here. So the environmental and family stressors are recorded by our social workers or our PhD psychologists when they do their intake evaluation. Unfortunately, that can vary from patient to patient. There's no strict definition. Thank you.
Thank you very much. Our next talk is entitled Risk of Neurodevelopmental Disability and Healthcare Needs in Extremely Low Birth Weight Infants with Necrotizing Enterocolitis or Spontaneous Intestinal Perforation, presented by Dr. Priyanka Chugh.
Sorry, I'm tall. There we go. All right, thank you. NEC and SIP are relatively common GI emergencies that impact premature and low birth weight neonates. And because of this, we'll be focusing on the extremely low birth weight neonates, which are those less than 1,000 grams. We know in this population that the mortality is very high for both NEC and SIP, but NEC has a higher mortality than SIP. Existing data shows that despite this mortality difference, both groups actually have very similar morbidity when you look at their initial hospitalization. We also know that NEC has an increased risk of long-term morbidity, especially clear when we look at neurodevelopmental disabilities. But this information is not quite as clear for SIP. So we looked at ELBW neonates from 59 North American neonatal intensive care units that are part of the Vermont-Oxford Network database, born from 2011 to 2018, with follow-up at about 2 years corrected age. 3 groups were looked at, which was the laparotomy-confirmed NEC, laparotomy-confirmed SIP, and those without either diagnosis. Our primary outcome was severe neurodevelopmental disability, and our secondary outcomes were weight morbidity with a weight less than 10th percentile and other markers of increased healthcare needs. We had 6,391 ELBW infants, the breakdown that you can see above. And when we compared NEC to SIP, we found there was no significant difference in any of our outcomes, pointing to what we thought, that NEC has also significantly increased long-term morbidity. We also compared our NEC and SIP patients to our control, and these are some of our significant findings. For NEC, we found that there was increased risk of severe neurodevelopmental disability, rehospitalization, and post-discharge surgery. For SIP, we also found an increased risk of post-discharge surgery. And while that's the only one that met significance, where you can see on our forest plot, everywhere where there was an increased risk of NEC, there was also an increased risk of SIP. This shows us that ELBW survivors of NEC have an increased risk of neurodevelopmental disability and healthcare needs. But this was already known in the literature. But what this study now shows us is that ELBW survivors of SIP also have a greater risk of long-term healthcare needs. And this can be used to counsel parents of patients that are survivors of SIP. Thank you.
In the never-ending debate about drain versus laparotomy, can you, any way to distinguish, not with your data here, but other data, is it the operation that is causing these problems, or is it the underlying diagnosis?
Of course, and thank you for asking that, because I didn't include it here, but we did do a subgroup analysis looking just at those who had drains to try and parse in that issue of anesthesia, if that's what's causing the increased neurodevelopmental outcomes, and we actually found that there was no difference. So it seems that it's the inflammation that is the issue with this group.
So people are free to do whatever they want still.
Yeah.
Great.
Do as you please. Thank you
very much.
Okay, our next talk is on I'm at that age. Priming of natural killer cells with neuroblastoma cells enhances natural killer cell release of granzyme B, presented by Dr. Colin Quinn from the University of Alabama. What's that? No institution.
Appreciate the promotion, but not quite a doctor yet. So thank you so much for giving us the opportunity to present our work today. We have no disclosures. So we know natural killer cells are an immune cell that will innately kill tumor and virus-infected cells, and they do so by releasing granzyme B containing vesicles. This granzyme B will then go on and induce apoptosis of its target cells, and the way we can measure granzyme B release is through the cell surface expression of CD107A on NK cells. Our lab has previously taken these natural killer cells, exposed them to neuroblastoma that's either been just neuroblastoma or infected with an oncolytic virus. And we found that this primes the NK cells and enhances their cytotoxicity against neuroblastoma. So we hypothesized that the mechanism behind priming and this increased cytotoxicity was due to an increased release of granzyme B. To test this, we took our natural killer cells and primed them with neuroblastoma, or neuroblastoma that's been infected with an oncolytic virus, and then assessed the CD107A expression on our NK cells. We found that under both conditions, the priming of NK cells significantly increased the CD107A expression, indicating that priming increases granzyme B release, and we know this because of that increase in CD107A expression on our primed NK cells in comparison to the naive NK cells that weren't primed at all. And this helps explain why we see an increase in cytotoxic effect from the priming of NK cells, because that granzyme B is inducing apoptosis. More importantly, the granzyme B is also creating a more immunoreactive tumor microenvironment, thus enhancing the anti-tumor immune response. So hopefully understanding these mechanisms behind priming and the dynamic between NK cells and neuroblastoma will improve immunotherapies and, more importantly, NK cell-directed immunotherapies towards neuroblastoma. So I'd like to thank my mentor, Dr. Byerly, the Byerly Lab, and Children's of Alabama for making this work all possible. I'll take any questions at this time.
Juan Correa from Cincinnati. Wonderful job. I wonder if there's any other way to prime these cells that is not with neuroblastoma. So
Yeah.
we can translate someday into.
Absolutely. No, I appreciate the question. Thank you. So they've shown in research that you can use just cytokines alone. But I think for me, what I would like to know is, can we give kids that have neuroblastoma NK cells, and these NK cells can stay primed? Because the biggest problem with neuroblastoma is relapse. So if we have these primed NK cells that are hanging out in a kid, will they be more cytotoxic if there were to be a relapse of the tumor?
Amar Hajat, Lurie Children's. Just wondering, I mean, this concept of NK cell memory is a fairly new concept. Is there a specific receptor that you're looking at that induces this NK cell priming or memory?
That's a good question. We have not looked at specifically what receptor. What I would like to do, though, is do RNA-seq, and I think genetically these NK cells that are primed are probably different than naive and unprimed NK cells. Thank you for your question.
Thank you.
Thank you.
The next talk is miRNAs contained inside human amniotic fluid-derived extracellular vesicles can be used as biomarkers of neuroinflammation severity in spina bifida aperta, presented by Ms. Lina Antonians.
Okay, chairpersons, ladies and gentlemen. In 2011, the MUMS trial reported better outcomes for patients who underwent prenatal surgery for spina bifida repair as opposed to postnatal surgery. However, more than a third still had poor outcomes, including the ones that were not eligible for surgery. The cause of these poor outcomes remains incompletely understood. Using experimental models, our team has shown that neuroinflammation is involved in spina bifida pathogenesis and could be key to explain these poor outcomes. However, there's currently no ways to measure neuroinflammation in spina bifida. Knowing the status of neuroinflammation would not only inform us on the pathophysiology, but give us an assessment for disease severity, which would guide appropriate counseling as well as patient selection for antenatal therapy. To look at neuroinflammation in the fetus, our team has focused on extracellular vesicles, or EVs. EVs are small nanoparticles that are secreted by all cells that carry cargo in the form of lipids, proteins, and small RNAs. EVs are considered to be the paradigm for liquid biopsies in clinical conditions for which tissue sampling is difficult. The first aim of the study was to isolate and characterize EVs from the amniotic fluid samples of fetuses with spina bifida. At Cincinnati Children's, we obtained samples from 6 fetuses undergoing repair surgery at the beginning of the procedure and compared them to 6 age and sex-matched controls of fetuses undergoing laser therapy for twin-twin transfusion syndrome condition. We used our established protocols to isolate the EVs, and we found that compared to controls, spina bifida EVs had a higher density, but both populations had typical EV size as well as expression of canonical protein markers. Next, we characterized the small RNA cargo by performing RNA sequencing. Here we're showing the top 100 differentially expressed microRNAs by the different conditions and split by patient. And if we zoom in on the top 10, we see that microRNA 148, 30D, for example, are the ones that are most highly differentially expressed, and they control processes like apoptosis, neural tube defect formation, pro-inflammatory conditions, as well as neuronal cell death and neurodevelopmental delay. So in conclusion, we've shown that EVs in spina bifida are a feasible source of microRNAs to assess disease severity. And next, we plan to correlate these with clinical outcomes as well as spina bifida severity, and also ask ourselves, where are these EVs coming from? Thank you very much for your attention. I'll take any questions.
I think we're short on time, so if no other questions, we'll keep going. Thank you. Next up, better late than never, a contemporary analysis of age at orchiopexy in U.S. hospitals by Ms. Sarah Gans.
Good afternoon, and thank you for the opportunity to present. So cryptorchidism is a common genitourinary condition. Research shows that it affects about 4% of infant males. And current guidelines recommend that surgical treatment is done via orchiopexy. by 18 months of age, and they cite testicular cancer risk and fertility risks associated with delayed treatment. Further research also shows that if you delay the treatment to after puberty, that also increases those risks. So as we know, a guideline is only as good as a field's ability to implement it. So we sought out to see how age of orchopexy has changed over time since the implementation of these guidelines in 2016. To do this, we queried the FIS database for all patients aged 0 to 17 years undergoing outpatient unilateral inguinal orchopexy. Importantly, we excluded any patients that were undergoing any other abdominal procedures at that time. We used the study period from January 2016 to December of 2021 in our analysis. And in our results, we found that there were 43,403 patients in the participating hospitals that had a unilateral inguinal orchopexy, and that the geometric mean age at orchopexy was 4.8 years. And in comparison to the 18-month guideline, this represents a significant delay. Importantly, nearly a quarter underwent orchopexy between the ages of 10 to 17, around the average age of puberty in males. Age of orchopexy was not associated with insurance status, surgeon type, or geographic location of the hospital, and the majority, 88%, were performed by pediatric urologists, with the remainder being performed by surgeons as well as other specialties. The figure here on the right shows that the mean age of intervention increased actually in our study period from 3.96 years in 2016 to 4.31 years in 2021. In conclusion, the age at orchopexy is highly variable and has not decreased over time despite the implementation of these new guidelines. And we'll have to do more research to figure out what exactly is explaining the delay so that we could have some targets to implement in policy. Thank you.
Are there any, I mean, obviously cannot answer it through FIS, but are there any policy statements in pediatrics that guide pediatricians probably as the source and maybe a delay there?
Yeah, so I know that it is the American Academy of Pediatrics recommends a routine investigation. You know, they always check to make sure that both testicles have descended. So it's possible, you're right, that referral could be explaining some of this as well.
So maybe you need to repeat this at the AAP. Okay, thank you.
Thank you.
Next presentation is optimized timing for surgical correction of pectus excavatum based on medial clavicle epiphyseal ossification, presented by Dr. Michaela Carter.
Thank you. Surgical correction of pectus excavatum is dependent upon chest wall pliability, and optimal timing is prior to complete skeletal maturation. However, at present, measures of bone age are not included in surgical planning for these patients. Therefore, surgeons are using age as proxy. So the objective of our study was to determine if a patient's bone age is associated with their preoperative pain as proxy for chest wall rigidity. Children less than or equal to 18 years old who underwent surgical correction of pectus excavatum between 2020 and 2022 were included in our study. All had a CT scan that was performed within 3 months of surgical correction. CT scans were evaluated independently by 2 radiologists and 1 surgeon. Bone age was determined by the Schmeling-Kellinghaus classification system. This looks at the medial clavicle's secondary epiphyseal ossification center, which stages the clavicle from the ultimate development in adolescence, and then finally fusion with the metaphysis, which happens typically in the mid-20s. 28 patients were included in our study, the majority of which were stage 1. Median age was 15.5 years, and when evaluating the inter-rater reliability, it was 0.95 between the radiologists and 0.78 between all raters. In order to create 2 more equal-sized groups, we grouped stages 2A and above into 1 larger group, and then looked at postoperative pain scores and their postoperative medication use. This figure demonstrates that for stage 1, the max pain score on postoperative day 0 and postoperative day 1, in addition to the narcotic use and the diazepam use, was less for stage 1 compared to more mature stages. So in conclusion, the Schmeling-Kellinghaus classification system is a valid proxy of a patient's skeletal maturity that can be used with high inter-rater reliability. And in our cohort, Stage 1 have less postoperative pain than more mature stages, which is likely a result of their increased chest wall pliability. This is all proof of concept that chest wall surgeons should be looking at a patient's bone age when considering timing of surgery. And in the future, we will be looking at the relationship between skeletal maturity with objective measures of surgical success. Happy to take any questions.
Hi, great talk. Shin Hiroshi, UC Davis. I was curious if you looked at hand x-rays in comparison to your clavicle x-rays, as I think those are actually the gold standard for bone age.
That's an excellent question. So that does actually require an additional imaging modality to be obtained. So we chose the clavicle because they already have a CT scan. So this doesn't expose the kids to any additional radiation.
Jean-Martin Laberge from Montreal. In relation to radiation, for pectus, we do limited CT, so we don't see the clavicles. So that takes out that equation.
It does.
And the second one is if you use intercostal nerve cryoablation, probably your pain scores will totally disappear because they're all really low after cryoablation.
Yeah, that's completely fair. Our patient population actually did receive cryoablation, however, and we still saw the difference. Thank you.
Thank you. Next up, C-arm cone beam CT localization of pulmonary nodules for thoracoscopic resection, a collaborative IR surgery approach in a hybrid OR presented by Dr. John Ricadia.
Disclosure, I'm an infiltrating pediatric interventional radiologist. So traditionally, pulmonary nodules have been localized by interventional radiologists under traditional CT. What we have at Cincinnati Children's is the ability to do these procedures together with our surgeons in our hybrid OR. We can do both the imaging, the localization, and the thoracoscopic resection in one setting. So the purpose of this study was to assess the feasibility, success rate, and complication rate of performing these localizations under cone beam CT guidance in the hybrid OR for thoracoscopic resection. So the pulmonary nodules are localized under an integrated navigational system where we combined a live fluoro overlay over the cone beam CT that was acquired in the room. The nodules were localized with Copan's needle wire technique, plus minus methylene blue blood patch, or plus or minus a little microcoil. There were 3 different pediatric interventional radiologists and 6 different pediatric surgeons. So we've localized 67 nodules in 56 patients. 9 patients have had 2 or more pulmonary nodules localized under that same anesthetic. The mean nodule size is 4.4 millimeters. And all the nodules were successfully localized using this technique and thoracoscopically resected, yielding metastatic disease, infection, inflammation, lymph nodes. There was a complication of a pneumothorax, which required a chest tube placement for subsequent localization of a second pulmonary nodule and a partially retained Copan's wire fragment. So in conclusion, C-arm cone beam CT localization of pulmonary nodules for thoracoscopic resection in a hybrid operating room is a safe and effective method allowing imaging and resection to be performed in a single operative setting. Thank you.
Hi, I was curious. That's a great talk. I was curious if you could tell us the average radiation dose and what that would relate to for us non-radiologists in terms of how many scans or how many x-rays?
Yeah, that's a good question. So we looked into that actually comparing a cone beam CT, which is like full collimation, is about a third to half the dose of a traditional CT scan. And then we can do a couple follow-up scans where we collimate to make a thinner slice on the area where the Copan's wire is. So that's a linear relationship in decreasing the field size for the collimation thickness.
Hi, can you hear me? Which sarcomas were you referring to for your metastatic lesions?
I don't have all that data to be honest. I'm not sure. Some of them were, I think, well, certainly Ewing sarcoma was one of them. There's a number of other ones that I don't know if Roshni's in the audience, if she remembers. She was the primary surgeon on the majority of these.
Were any of them osteosarcoma?
Thank you. So I'm really sorry. Kathy's going to take my head off if we don't cut it off. Thank you. Can I go ahead?
Our next talk is entitled Contemporary Management of Congenital Diaphragmatic Hernia Repair, a Survey of Pediatric Surgeons, presented by Dr. Christina Teodoro.
Thank you for the opportunity to present our work. How do you hit the next slide? Big green one. There we go. So as a member of the APSA Fetal Diagnosis and Treatment Committee, we became interested in learning more about the current practice patterns regarding surgical management of CDH, in particular with the approach to patients with large defects that may not be amenable to primary repair. So we distributed a survey to members of APSA and as well as on social media. We received 235 responses. These were from surgeons who had been in practice for a median of 14 years. These surgeons reported performing a median of 8 CDH repairs per year per center. And of these respondents, 15% reported that they limited CDH repairs to a select group of surgeons at their institution. And about a third reported that they have a multidisciplinary CDH clinic for follow-up after hospital discharge. With regards to CDH repair methods, among the repairs done in the past 5 years by the respondents, about 2/3 of respondents had performed a mixture of primary and patch repairs, and about 10% performed only primary repairs in the past 5 years, and 10% performed a mixture of primary, patch, and flap repairs. When faced with a defect that was not amenable to primary repair, 82% reported preferring patch repair, while 11% reported preferring flap repair, and the remainder had no preference. Among types of patches available, Gore-Tex was the most commonly used patch, and the transversus abdominis muscle flap was the most commonly used muscle flap. We also asked a few questions about patients on ECMO, and one of the interesting findings was that chest tubes are more commonly placed in patients repaired on ECMO, presumably for bleeding risk postoperatively. When we asked about why patch or flap was preferred for repair of large defects, these are the most common reasons cited by each group. So for patch preference, people cited prior training in patch repair and little to no experience with flap repair as the two most common reasons. And among surgeons who prefer flaps, the reasons cited were potential decreased hernia recurrences and potential for flap growth with the child. So in conclusion, we found that there was varying approaches to the repair of CDH, especially with regard to large defects, and further research is needed to determine the efficacy of these two approaches and to determine long-term outcomes of these cohorts. Thank you.
Thank you. All right, I think for the sake of time, we'll go on to the next one. Thank you very much. The next presentation is entitled Lidocaine Infusions Reduce Postoperative Antiemetic Use After Sleeve Gastrectomy, presented by Dr. Devon Pace.
All right, thank you for the opportunity to present our work, and apologies in advance, I'm still recovering a little bit from a cold from my child, so. As has been discussed multiple times in other presentations, the obesity epidemic is a critical problem in adolescents and has tripled over the last 3 decades up to around a prevalence of around 22%. This means that pediatric surgeons are seeing more patients with severe obesity that are qualifying for bariatric surgery. One of the most frequent complications following bariatric surgery is postoperative nausea and vomiting. And given this, our anesthesiologists were trying to identify ways to minimize PONV in this patient population. And there's some literature looking at lidocaine infusions, which have been shown to have some anti-inflammatory, analgesic, and antiemetic properties. And so we began offering lidocaine infusions in this patient group beginning in September 2021. So our hypothesis was that children receiving lidocaine infusions would have decreased rescue antiemetic use, earlier time to oral intake, and this would translate to shorter length of stay in the hospital. So we performed a retrospective review from January 2018 through December 2022 for all patients undergoing sleeve gastrectomies. And we compared outcomes based on children who did not receive a lidocaine infusion. The outcomes specific of interest were pain scores, opioid use, rescue antiemetic use, time to oral intake, and PACU and hospital length of stay. There were 89 total patients included in the study, 70% of which were female. 31 patients received a lidocaine infusion. And there were no differences between groups in comparison between demographics and specific clinical measures. Pain control and opioid use were similar between groups. However, patients who received a lidocaine infusion used significantly less rescue antiemetic, which is in our hospital ondansetron. They used 8 milligrams versus 16 milligrams in the no lidocaine group. And they had significantly reduced hospital length of stay as well at 33 hours versus 54.5 hours. They additionally demonstrated earlier time to oral intake at 4 hours versus 5.5 hours. Ultimately, the mechanisms behind lidocaine infusions are not well understood, specifically regarding PONV, and the optimal dose is also not well understood either, and it's currently being studied, but a safe dose has been shown to be up to 1.5 milligrams per kilogram per hour. Ultimately, we believe that IV lidocaine is a reasonable option to include in ERAS protocols to enhance the postoperative experience, and targeting PONV will help enhance the patient experience postoperatively, as well as potentially significantly expedite hospital length of stay. Thank you.
Any questions?
All right, I think for time purposes, we'll move on to the next. Thank you so much. Our next talk is entitled Postnatal Fate of Donor Hematopoietic Stem Cells After Transamniotic Stem Cell Therapy, TRASCET, in Healthy Syngeneic Model P, presented by Dr. Kamila Moskovitsova.
Thank you. Good afternoon, and thank you for the opportunity to present. Transamniotic stem cell therapy, or TRACET, is a minimally invasive strategy for fetal cell therapies potentially applicable for a variety of fetal diseases. Hematopoietic stem cell is one of the 3 types of cells that are described up to date as compatible with TRACET. When using those type of cells, TRACET could be relevant to various diseases like hemoglobinopathies, immunodeficiencies, inherited metabolic diseases. Regulatory feasibility of clinical trials of TRACET is contingent on the postnatal fate of the donor HSCs, as potential malignization and immunogenicity of these cells possibly lingering in the host is a concern. So we sought to examine the donor HSC fate after birth following TRACET in a healthy syngeneic model. On gestational day 17, or E17, fetal rats underwent intraamniotic injection of HSCs labeled with a luciferase or a cellular luciferase only as a control. Then 7 and 21 days following spontaneous delivery, samples from 10 fetal sites and 2 maternal sites were collected. Overall survival to term was 44%. And there were no significant differences in survival from term to either P7 or P21. When controlled by a cellular luciferase, donor HSCs were identified in spleen, intestine, brain, and liver in samples from the neonates at P7, but in none of the samples from the neonates at P21. No luminescence was detected in any maternal samples at any time point. In conclusion, although present and 1 week after birth at select neonatal sites, donor HSCs were not detectable as early as 3 weeks after of postnatal life after intraamniotic injection in syngeneic healthy model. Transamniotic hematopoietic stem cell therapy may be safe and amendable to eventual regulatory approval for clinical trials. Thank you.
Questions from the audience? All right, what are the next steps in your study?
Thank you for the question. Yeah, obviously we did do multiple studies with a prenatal and prenatal sort of evaluation of the donor, of the fate of the cells. This was the first study looking at the postnatal fate. We would like to also examine sort of the different genetic makeup of the cells and their eventual postnatal life.
Thank you very much. The next manuscript is entitled Prospective Validation of Hirschsprung-Associated Enterocolitis Scoring System, presented by Dr. Ruth Lewitt.
Good afternoon. So as we all know, Hirschsprung's associated enterocolitis is a life-threatening condition, but is often difficult to diagnose with nonspecific symptoms. 2 previous scoring systems were developed, but have not been widely adopted in clinical practice. So a novel scoring system was recently published, aimed at reducing the underdiagnosis of HAEC, and the purpose of this study was to prospectively validate that scoring system. So it was a multi-institutional prospective study at 4 independent children's hospitals. Every encounter for all patients with Hirschsprung's disease under 18 years old were included during our time period. For the purpose of this study, a true diagnosis of HAEC was considered those that received the gold standard treatment of bowel rest, antibiotics, and rectal irrigations. We had 95 patients with 293 patient encounters. Of those, we had 98 cases of HAEC in 54 of our 95 patients. Of note, only 19 of those encounters with HAEC had a diagnosis of HAEC documented in the EMR. We then compared the 3 scoring systems, looking at all 3, looking at the sensitivity, specificity, positive and negative predicted value, odds ratio, and univariate analysis, and area under the curve of the ROC curves. We found that the Pasteur score maximized specificity, positive predictive value, and odds ratio, while the Lewitt-Veris score maximized sensitivity, negative predictive value, and area under the curve. So in conclusion, all scoring systems perform similarly. However, the Lewitt-Veris scoring system maximized sensitivity, negative predictive value, and AUC, while also having fewer data points and therefore may be more useful in a clinical scenario. Thanks, and I'll take any questions.
So since the risk of missing a diagnosis is so high, potentially, the sensitivity is pretty low, the negative predictive value is relatively low, what ways can we make those numbers better so you can confidently discharge somebody based on the scoring system?
That's where this is so difficult, because the sensitivity is so low, most likely because all of these are nonspecific symptoms. And so our next step in this study is going to be to look for a clinical biomarker in the stool where we can actually have a actual laboratory result that would help us.
Okay, see you next year.
Thank you very much. The next presentation is entitled Metabolic Bone Disease and the Effect of Pucertal Onset of Pediatric Intestinal Failure, presented by Dr. Emily Ness.
Thank you for this opportunity to present our work. While the prevalence of metabolic bone disease has been cited as high as 34% in pediatric intestinal failure, the effect of puberty on bone mineral density in this population is unknown. The aim of this study was to identify the impact of puberty on bone mineral density in pediatric intestinal failure. This was a retrospective review of children in an interdisciplinary intestinal rehabilitation program who underwent puberty and had at least 2 DEXA scans from 2008 to 2021. Adjusted bone mineral density z-scores greater than 2 standard deviations below average was diagnostic for metabolic bone disease. Univariate and multivariable analysis identified predictors of metabolic bone disease and pediatric intestinal failure. 46 patients were evaluated, 72% had metabolic bone disease, and although not significant, the trend of adjusted bone mineral density z-scores appeared to decrease over time, suggesting that compared to children their age, our cohort of children with intestinal failure had lower bone mineral density over time. Pubertal onset did not significantly impact adjusted bone mineral density z-scores, nor did PN dependence, history of fracture, or vitamin D deficiency. Multivariable analysis identified weight for age z-score as the only significant independent predictor, with higher weight being associated with higher adjusted bone mineral density. In our cohort of children with intestinal failure, puberty did not improve adjusted bone mineral density z-scores.
and weight for HC score was the only significant independent predictor. Children with intestinal failure are at increased risk of osteoporosis as they get older compared to their healthy peers. These findings emphasize the importance of optimizing nutrition to promote weight gain and mitigate the risk of metabolic bone disease and pediatric intestinal failure. I'd like to thank those listed for their help and support in this project. Thank you for your time. I'd be happy to answer any questions.
If there are no questions from the audience, I think we'll move on. Thank you very much.
Thank you.
All right. Our next talk is entitled Transamniotic Stem Cell Therapy, TRASCIT, Modulates Uterine Natural Killer Cell Activity in a Model of Intrauterine Growth Restriction, IUGR, presented by Dr. Ashlyn Whitlock.
Good evening, and thank you for the opportunity to present our work. We have nothing to disclose. Intrauterine growth restriction, or IUGR, is driven by abnormal uterine natural killer cell, or UNK cell activity, leading to placental dysfunction. It begins with increased IL-17 signaling that starts with placental hypoxia, and this stimulates UNK cells to release pro-inflammatory and angiogenic cytokines, such as interferon gamma, TNF-alpha, and VEGF, which all contribute to placental dysfunction and poor fetal growth. TRACIT with mesenchymal stem cells, or MSCs, involves the simple injection of large amounts of these cells into the amniotic cavity, where they traffic robustly to the placenta. We have shown that TRACIT can improve outcomes in the fetus in a model of IUGR. We therefore aim to better understand the mechanism of that protection by assessing markers of UNK cell activity in the placenta. To do this, we used a well-established rodent model of IUGR that uses hypoxia in the final week of pregnancy. Animals were divided into 4 groups. One group had no further intervention, while the others underwent intraamniotic injection of either saline or amniotic fluid-derived MSCs. A subset of the donor cells were primed by exposure to pro-inflammatory cytokines prior to their injection. We also analyzed normal controls not exposed to hypoxia for a total of 222 fetuses. Placental efficiency was significantly decreased in untreated and sham groups, indicating successful replication of the IUGR model. It was normalized in both TRACIT groups along with the maternal adjusted fetal weight. Placental IL-17 was elevated in all experimental groups exposed to hypoxia, again confirming the model. Placental interferon gamma and TNF-alpha, both released by activated uterine natural killer cells, were elevated in untreated placentas but comparably lower or even normalized with TRACIT. Placental VEGF, also released by these UNK cells in a marker of angiogenesis, was elevated in untreated and sham, but actually lower than normal in both TRACIT groups. In conclusion, TRACIT reverses core effects of IUGR in a rat model, likely due to modulation of placental UNK cell activity. This reduces downstream inflammation and enhances angiogenic signaling, improving the placental dysfunction associated with IUGR. This mechanistic insight may inform the development of novel strategies for the management of this very prevalent disease. Thank you, and I look forward to your questions.
All right, I think we'll move on to the next one. Thank you so much.
All right, next up, a novel method of ultrasound-guided in utero injection to colonize mouse embryonic intestine with the human gut microbiome, presented by Dr. Koichi Tsuboi.
Okay, thank you for the opportunity to present my work. Research involving the in vivo fetal models is essential, though it is challenging to create a new ideal model given the unique intrauterine environment. Here report a successful injection of a neck-inducible bacteria into the mouse fetal stomach using microinjection system, and we got some insights to the immune development and differentiation in the intestine. Okay. So this slide shows the how the injection is performed. The 1 centimeter incision laparotomy is done and the embryos are exposed. Using under the ultrasound guide image, the needle, glass needle inserted into the lumen of the fetal stomach is shown on the right side of this ultrasound image, and neck-inducible bacteria is directly delivered to the lumen of the intestine. The 48 hours, the samples are collected for analysis. All the littermates that had no injection also collected for the analysis.
The 16S PCR reveals the presence of bacteria in the fetal intestine 48 hours injection, whereas the non-injected the fetus did not have any bacterial presence, showing indicating no contamination was occurring. Regarding the pro-inflammatory cytokines of TNF-alpha, IL-1 beta, and lipokine-2, the injected group had a significant higher elevation in these levels compared to the controls or the sham group. And the MYC2 genes also were higher in the fetal intestine of the injected group. And consistent with the results, the Alstrom blue staining, Alstrom blue staining revealed the increase of number of goblet cells per villi. Furthermore, regarding to the stem cell markers, Notch1 expression was significantly suppressed, but not HES1 or LGR5 did not have any change. So in conclusion, the bacteria injection model seemed to be successful. The injection induced the inflammatory response to the fetal intestine, and there was a MYC2 elevation and the differentiation towards the increase of goblet cells. Thank you. Questions? What are next steps? When and how else might you use this for other? What other applications are there for this? Thank you for the question. So I think we should see more in detail which cell type or differentiation change had occurred to this exposure to the pathogens. And I've been very curious about the second hit or the infection after birth these neonates occurred and how they respond to these pathogens.
Thank you very much.
Thank you. Next up, implementation and validation of a novel severity grading system for unexpected events in pediatric surgery, the Clavian-Madadi classification, presented by Dr. Amit Madadi-Sanjani.
Thank you very much for the opportunity. So severity grading systems are an essential part of the surgical literature, and the Clavian-Dindot classification is the most important one, cited more than 20,000 times in the literature. That's an incredible number. It's been used in pediatric surgery, but it's never been validated, and several drawbacks have been reported. So the novel Clavian-Madadi classification has been tested in more than 17,000 patients, and it seems to be a feasible instrument, and we're now aiming to validate it in two stages. First of all, correlation of the procedure complexity and the severity of events, and then the second step, we've circulated 19 case scenarios of complication and unexpected events within the EU surgical network. And that's the novel classification. So you see we have a novel grading, the grade 1A now including any deviation from the planned perioperative course, including management and organizational errors. We have changed the stratification of grade 3 from the anesthetic management, from the anesthesiological management to the invasiveness of procedures, and we've reduced the organ failures, as already done in the pediatric literature, to a single grade. And in the step 1, we've seen that we have a higher correlation of the procedure complexity with the novel instrument, and that repeats for the sentinel events, the events that we most focus on. For the step 2 validation, 57 surgeons from the EU countries replied, and we've seen that there is a superior agreement and grading with the novel instrument, there is a superior intra-class correlation coefficient, and it is the preferred instrument by the majority of surveyed European surgeons. So this is the first ever validated classification system for the severity grading of unexpected events in children. And it will be implemented into the registry of the European reference networks of inherited and congenital anomalies this year. So the last thing to say is a plea, use it now in the American networks as well, and let us get the quest together for uniform reporting of outcomes. Thank you.
Well, just a comment. I, first of all, am jealous because I wish my name was on a scoring system that I could have thought of. But I think this is really great work. It's really important to have a validated system to score these complications, and I applaud your work.
Just a short comment. I wanted to call it the Hanover classification, but Professor Pierre-Alain Clavière supervised our project, and this was one of the things he wanted, his name in the project. So
Fair.
I had to stick with that. Yeah.
Next is small bowel obstruction following congenital diaphragmatic hernia repair, evaluation of risk factors and operative approach, presented by Dr. Nicholas Schmucki.
Thank you. I'm a pediatric ECMO and surgical research fellow at Columbia University, and I'm going to be presenting our work today on small bowel obstruction following CDH repair, evaluation of risk factors and operative approach. We completed a single institution retrospective review of all CDH births between 2010 through 2022 and identified 120 patients that underwent repair for their CDH. We had an average length of follow-up of 54 months, and we found that 13% of our cohort developed a small bowel obstruction, and of those, 94% required operative intervention. The median time to small bowel obstruction was 7.5 months, with a range from 1 to 126 months. When evaluating risk factors associated with developing a small bowel obstruction, we found that patients that required ECMO, those that had a longer median time to repair, those that required additional abdominal operations, including a G-tube or a fundoplication, as well as those that had a longer initial hospitalization, had an increased incidence of small bowel obstruction. We performed a secondary analysis comparing open to minimally invasive repair and found no difference between the two. When comparing a primary to a patch repair, we found that patch repairs did have a slightly increased incidence of small bowel obstruction, although this did not reach significance. We therefore concluded that neonates with increased acuity of illness, including those requiring ECMO, additional abdominal operations, longer time to repair, and longer initial hospitalizations, were associated with increased incidence of adhesive small bowel obstruction, and that more than 90% of CDH patients with small bowel obstruction required surgery. Thank you.
Great presentation, Frischer, Cincinnati. I trained at Columbia before your cohort was conducted, and Charlie at that time said any bowel obstruction that came in with a CDH patient, we took immediately to the operating room, or you would never let the sun rise or set on a patient with CDH. So that was my training before this. Did something change, or do you have a different approach now? Because you said there was 6% or something of patients that you didn't operate.
That was Charlie falling, by the way.
Yeah, I believe it. So did something change? And then we had that talk earlier about using gastrograph and study and bowel obstruction. Was that used in any of these patients, or what's your current algorithm for treating these patients? Thank you.
Using a gastrograph and protocol is becoming much more common for us at our institution. Within our cohort, 55% of the patients had a gastrographin challenge, and the one successful patient that was managed non-operatively received gastrographin as well.
I can't help it. Dr. Wilkin just walked in. Do you think your a described approach to patch repair is going to have a lower incidence of bowel obstruction going forward?
I don't.
Okay, then sit down, please. Next.
Okay.
No, go ahead. No.
No, what I was going to say is I think on the, your numbers on the number of minimally invasive repairs is very low. So
Yeah.
I don't know that you're powered to show any real difference. I know when we looked at our series at Emory and looked at it was a retrospective study, there was a huge difference between the incidence of bowel obstruction of open versus the thoracoscopic repair. But then as soon as you put a real patch, not just a reinforcing patch, as soon as you put a real patch in, that all went away because the patch just totally dominated. If you have a patch, your incidence of bowel obstruction is going to be real.
Makes sense. Thank you.
Thank you both. Next up, leveraging consumer wearable devices to examine disparities in postoperative recovery trajectories after pediatric appendectomy, presented by Dr. Sahel Zainadine.
Thank you for the opportunity to present. Postoperative recovery is a multidimensional process with physical, mental, psychological progress towards equilibrium. Wearable devices we've shown before, such as Fitbits, can provide objective physiological data about recovery, and we noticed that different diseases have different recovery trajectories, even simple and complicated appendicitis. Neighborhood level social determinant of health can negatively affect clinical presentation, even outcomes. People have more abscesses, come in more perforated. However, the effect of this on normal recovery is not really well defined, and that's what we wanted to look at. We included patients from 3 to 18 years old who underwent laparoscopic appendectomy, divided simple and complicated. They wore the Fitbit for 21 days from the day of surgery, in the hospital and at home. We excluded patients with complications and who did not wear the Fitbit because we're trying to find normal recovery. We assess the neighborhood level social determinant of health using Child Opportunity Index using the census tracts for each patient. And we divide the groups based on the COI score to low and high, the low being the lowest 2 quintiles and high being the high 3. And we use segmental regression models to estimate and show recovery trajectories for these patients. So totally, we included 147 patients, 68 for simple appendicitis, about split half and half, low and high COI. We can see in red, our patients with high COI reach a plateau on the postoperative day 8, while those from lower COI groups reach the plateau on postop day 14, which is about 6 days later. In patients with complicated appendicitis, sorry about the typo, more patients had low COI, which we probably know from before, but in this case, the perforation kind of took over. It takes longer to recover, and there wasn't much of a difference between the two groups. We have some limitations. It's single center, single procedure. This is API. They all came through the ED. We don't have their baseline. In conclusion, we do note some disparities that are not covered by traditional outcome measures, such as readmissions, abscesses, reoperations. And this highlights needs for policies and resource allocation to address these disparities. Thank you.
I have one quick question for you. I think this is a great idea and a great way of measuring both postoperative outcomes as well as disparities. What were the percentage of patients that did not wear their Fitbit for 21 days?
Actually, it wasn't too bad. It was about 12%-ish, yeah, of the people we recruited.
Thank you very much.
Thanks.
All right, next. Airway management and outcomes following Fetal, a single-center descriptive analysis presented by Dr. Oluyinka Olatoye.
Thank you for the opportunity to present. Congenital diaphragmatic hernia is a complex disease associated with pulmonary hypertension and pulmonary hypoplasia, which was shown to be alleviated by fetoscopic endoluminal tracheal occlusion, or FETO. FETO has also been shown to increase the size of the trachea, and this increase in size has been shown to not cause negative outcomes in this patient population. However, the effect of airway management concerning endotracheal tube and associated procedures is poorly understood in this population. And so to further understand this, we took a 10-year cohort of patients at our single institution that had undergone FETO, and we had a single radiologist that was blinded take a look at their first chest x-rays at birth and to determine whether or not they had tracheomegaly, with tracheomegaly determined to be 8.8 millimeters, which is 2 standard deviations from the mean. And what we found was that even when we standardized these patients had very large trachea sizes. If you look on the first row in red at the far right, you'll see that the median for all patients was 9.9 millimeters, with the lower percentile being 8.7, and our cutoff was just 8.8. And if you look at all the patients, a lot of these patients had high incidence of needing to upsize the endotracheal tube due to a leak. And this was associated with further bronchopulmonary procedures. At our institution, it's our protocol to, in these very premature low birth weight patients, to intubate them with a size 3 endotracheal tubes, uncuffed. And given these results and the need to frequently upsize them, we recommend considering putting a cuffed endotracheal tube or even a bigger size at birth. Thank you, and I'll be happy to take any questions.
Do you have any input from your neonatologists? I think their concerns about cuffed tubes probably are old, like before your time. But, about tracheal acquired stenosis or injury.
Definitely, that's an ongoing discussion. Was actually the impetus for this study. So we are bringing this data to them to find a way forward with protocols.
Anybody else? All right, thank you. Last today, trends in the operative management and timing of resection in pediatric congenital pulmonary airway malformations and ACS NISQUIP pediatric study presented by Dr. Alicia Green.
Thank you.
Congenital pulmonary airway malformations, or CPAMs, are developmental anomalies of the bronchial tree that result in abnormal proliferation of lung tissue. In North America, surgical resection remains the mainstay of treatment, preferably while the patient is asymptomatic. However, the optimal timing for surgical resection is unclear, and many have advocated for earlier resection to avoid infection and subsequent inflammation or adhesions, as well as for definitive diagnosis. We aim to assess the national trends in CPAM resection in terms of approach and age of resection using the NISQIP-P database from 2012 to 2020.
Lisa, do you want to answer?
First, looking at the trends in operative approach over time, we found that the thoracoscopic approach significantly increased from 45% in 2012 to 70% in 2020. When looking at the trends of operation subgrouped by age of operation, there were slight changes over time with no statistical significance. Most operations were performed in patients 6 to 12 months of age, as seen in gray. We next evaluated the clinical outcomes for this population after surgical resection. Our cohort consisted of 1,721 patients. Patients that had surgical resection at less than 3 months old were more likely to have ASA4 classification, preoperative conditions, and undergo an open approach. In a multivariable analysis, patients less than 3 months were more likely to have shorter operative times, but longer postoperative length of stay. Patients older than 6 months were less likely to have bleeding complications requiring transfusion, but had longer operative times. In conclusion, there has been increasing adoption of the VATS approach for CPAMs over the last decade. Despite increasing cause advocating for earlier resection in this population, we have not observed any major changes in timing of surgery during the study interval. Though surgery-specific data is not available in the NISQIP participant use file, this data suggests that surgeons continue to operate in the range that they feel most comfortable with similar results within the limited outcomes available in NISQIP-P. Thank you, and I'd be happy to take any questions.
Get up without David calling on me this time. Just a quick question. On your patient, did you notice, or did you look at the conversion rate, or are you able to see the conversion rate of the thoracoscopic patients in the NISQIP database? And was there an increased conversion rate in those older patients compared to the younger patients?
Thank you for that question. So as conversion is not a listed CPT code, but we did look for other or concurrent CPT codes for an open approach, and then we considered those to be a conversion. And we found that the conversion rate was similar between all ages of patients. There was no statistical difference. Thank you for that question.
All right, thank you. On behalf of Dr. Slater and me, thank you for your attendance. Apologies for my being late, and I think we're a bit early, so enjoy the rest of the day.